Good to go. Great. Well, I'll go ahead and start. Hi, everybody. Good afternoon, and hope everybody's having a safe and healthy day and week. My name is Jay Bernhardt. I'm the Dean of Moody College of Communication here at the University of Texas at Austin. It's my pleasure and honor to welcome you to one of our most prestigious annual speaker series, the John P. McGovern Lecture in Health Communication. Thanks to a generous gift we received back in 1983 from the John P. McGovern Foundation, this McGovern Lecture was established, and each year we host a leading figure in healthcare or communication to speak to our community about important issues of the time. Recent McGovern lecturers have included Pulitzer Prize-winning author, Dr. Siddhartha Mukherjee, former CDC director, Dr. Julie Gerberding, and executive director of the Haag Foundation for Mental Health, Dr. Octavio Martinez Jr., among many other prestigious speakers. And now I'd like to share a little bit of information on the person for whom it's named, John P. Jack McGovern, and why we're so honored to hold this event in his memory each year. Dr. McGovern was a noted allergist, scholar, and philanthropist, and was considered one of the state's and country's most important figures in the history of medicine and healthcare. The son of a surgeon, he graduated from Duke University School of Medicine in 1945. He served in the Army Medical Corps, and in 1951 began teaching, first at George Washington University Medical School and then later at Tulane Medical School. And in 1956, he moved to Houston to join the Baylor faculty. He opened an allergy clinic in Houston, combining hands-on medical practice with research and teaching, publishing dozens of articles and books about allergies and asthma that were highly regarded worldwide. But he was most known for was his devotion to compassionate patient care. He believed strongly in the humanistic approach, treating the whole person and not just the illness. McGovern said that he learned his lessons about generosity from his grandmother. As a child, he saw her feed the hungry from her home in Washington, D.C. during the Great Depression. And to quote McGovern, quote, "I learned from watching my grandmother that giving and receiving is the same thing." It's now my pleasure to begin our program and introduce to all of you Dr. Michael Mackert, the director of the Center for Health Communication in the Moody College of Communication and the Dell Medical School, to introduce our distinguished McGovern Lecture speaker for this year. Thanks, and take it away, Mike.
Well, thanks so much, Jay. Well, on behalf of our entire Center for Health Communication team, I want to welcome everyone to this event. Every year, the McGovern Lecture is one of our biggest and most exciting days, a chance to bring in people who think about health comm from a lot of different fields to come in and give an exciting talk and learn with them and be in conversation with them. And so I especially want to thank Brianna because of the work she does as our event planner, but our entire CHC team for planning and promoting an event that's always a highlight in our year. And I know today's going to be no exception. So anyone who knows me knows that I have a bit of a podcast habit, shall we say, and I tend to listen to too many podcasts at double speed to get through more. And I don't think there's anyone who's been as consistently in my ear as Dr. Scott Gottlieb in the last 2 years. And I mean consistent in that every Sunday morning on CBS Face the Nation, doing lots of interviews and just sort of being in public talking about COVID-19 a great deal, but also really consistent in his approach. Like COVID-19 has been a hard thing to communicate about. I remember the 3 months that we all wiped down our groceries with Clorox wipes. And so it's been hard, as what we know changed, to be even-handed and clear. And I've really admired the way he's been on the kind of public communication side of this. And I was listening to an interview and I shared something that I thought he sparked, and Scott actually retweeted it. And I learned what happens when someone with 500,000 Twitter followers retweets something. My phone became kind of unusable for a little while. And but it sparked kind of the idea of bringing in someone who's been on the public-facing kind of communicator side of COVID-19 for 2 years as someone we really want to welcome. And so Dr. Scott Gottlieb served as the 23rd Commissioner of the Food and Drug Administration, and he's the author of the New York Times bestselling book, Uncontrolled Spread, Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic. He's currently a fellow at the American Enterprise Institute and serves on the boards of Pfizer and Illumina. So please join me in welcoming our 2022 McGovern Award recipient and lecturer, Dr. Scott Gottlieb. We're so excited to have you with us today.
Thanks for hosting me. I appreciate it.
So
please
go ahead.
No, I was going to let you. I was going to open it up to you to start.
All right, perfect. So the interview I was speaking about, you were on KCRW Left, Right, and Center, and the host asked you something about sort of, do we need more conservatives in public health? And your answer was kind of revolved around the idea, I think, of, if we had more conservatives working in public health, we might have done a better job for a couple of years communicating with conservatives about masks and vaccines and all kinds of things related to COVID. And, as a person who thinks about health communication a lot, I like to think that if we know our audience really well, we can communicate effectively with people we don't necessarily agree with. But I wanted to sort of open it up there, because I think thinking about how we communicate with people who are conservative versus liberal and all over the place politically, I think is a real skill and something you seem to have demonstrated ability. So I'd love to open it up as kind of as an opening point of kind of how you think about the value of intellectual diversity within public health, and how you think about that in the communication work you do, kind of speaking to the whole country.
Yeah, well, look, I'm a political conservative. I worked in the Bush administration, the Trump administration. I work at a conservative think tank now, although the conservative sort of perspective on public health has kind of migrated to a place that's unfamiliar to me, and I think was problematic in the setting of COVID. I mean, I think, historically conservatives did public health well. I think in the Bush administration, there was a lot of emphasis on public health measures, the things we did under PEPFAR, the pandemic planning that we did back in 2005. And, some elements of the conservative movement now, I just don't recognize anymore. But I also have a feeling, my belief, and this, is sort of colored by my perspective, my orientation as a conservative, and also the biases I bring, that the public health movement generally, more broadly, is left of center. And I think at times it was doctrinaire in the setting of COVID, and, sort of kind of shut down some legitimate debate that we should have had, and at the very least should have been more in the open. I mean, I think we should have had a healthier debate around the utility of the employer mandate. To me, I said at the time, I thought that was a bridge too far, that whatever the incremental gain was going to be from a public health standpoint, and it was going to be incremental gain in terms of getting people vaccinated, that it was going to be offset by hardening opinions around vaccines and potentially creating a backlash that would spill over into other vaccine settings. We would see rates of vaccination for measles and flu go down because you'd suddenly have people look at the idea of a government telling you to get a vaccine as an intrusion of liberty, and things that we long accepted, like going out and vaccinating your kids with the childhood immunization schedule, would suddenly become a political issue. And I think that that's happening. And we didn't really want to have a debate about that. When I raised it, I got a lot of pushback. And I also got pushback when I raised sort of doubts about the public health infrastructure that now seem, socially acceptable, but at the time didn't. And I'll give one example. I was on Face the Nation probably late summer of 2020. And I said in one of the episodes, that I felt that the CDC had fed bad information to the White House and advised them poorly, and that contributed to bad policy decision making. And I got roundly attacked on Twitter. I had senior public health officials calling me, telling me how corrosive that comment was for the whole public health movement, that I was sort of impugning the CDC and creating excuses for the Trump administration's mismanagement of COVID. I wasn't defending the Trump administration. I acknowledged there were a lot of mistakes made, but I was just making an observation that CDC wasn't surfacing good information and doing good real-time analytical work and informing policymakers. And I had a basis for it. I had been in touch. I'd been talking to the White House at the time, a lot of senior officials. I had seen some of the things the CDC was saying and some of the documents, and they just didn't seem credible to me. I mean, going back to the earliest days where CDC was adamant that there was no community transmission as late February. And I kept telling White House officials, I kept saying it's impossible. There has to be transmission. We're just not detecting it. We don't have a test. And senior White House officials would say to me, look, I don't know what to tell you. They come into the meetings and they're adamant that there's no community transmission. And I'm not sure it would have made a difference if they were more circumspect and CDC didn't over-rely on the flu surveillance data, which is what they were looking at, which turned out to be a poor predictor of spread. But the bottom line is they made bad information available. And now, people kind of accept that, they recognize it. And I think that there's a willingness to acknowledge it and think about how we reform CDC going forward and build the right tools and capacities and resources. But the idea that I couldn't even raise that issue and have a thoughtful discussion around it, that my motives were impugned. I was criticized as trying to do the bidding of the Trump administration, or being a shill for the industry, and all kinds of terrible things were said about me on Twitter by not just trolls, by prominent people. It would surprise me, and it sort of is. That is one example of some of the behaviors that I've seen.
Okay, well, and
I'm glad you let me get that off my chest.
No, I can only imagine what that would what it's got to be like to be speaking in quite that way. And it's a related kind of question and issue. I think I've certainly heard you speak about public health as a national security issue, and I know there's certainly people in public health who don't love the idea of framing it that way. But I can also imagine it's a way to get some people to listen to you or care or think about investing who otherwise might not. So would you be willing to share a little bit about sort of how have you always thought about it that way? Is that a way you learn to sort of navigate different constituencies and thinking about how you get them to be interested in public health? I'm curious what you think about that.
Yeah, no, I think it's a good observation and a fair observation that if we looked at public health through a national security lens, that it would broaden the scope of people, I think, who would see it as something worth investing in. To me, that's not the reason I've sort of framed it that way, and I don't think it's the reason to frame it that way. I think the reason to frame it that way is because it's the reality. I think that public health preparedness generally is a matter of a national security. We've seen that in COVID. COVID changed the geopolitical, the course of world history. It set the United States back in terms of its geopolitical objectives. Would China have, cracked down on Hong Kong if it wasn't under the sort of, smokescreen of COVID? I don't think things would have happened that have happened in the world. And look, this crowded out all of our other national priorities. It costs us trillions of dollars. So I think we have to look at hardening ourselves to these kinds of risks as a matter of a national security. And to me, that's just a fact. You're right. It will broaden the universe. I think conservatives, national security conservatives will pay more attention if it's framed that way. A good outcome, but not the reason to frame it that way. And you're right that the traditional public health crowd is very nervous about that kind of language because they think, and they're right. Look, science relies on global cooperation. Proper public health preparedness relies on multilateral efforts and capacity building in places in the world where these infections emerge. And if you start involving the spy agencies in this mission, it could encroach on the ability of our scientists to work in an unfettered fashion globally. I get that. And I think that these two missions need to be distinct. The reality is that every American scientist who's operating overseas is perceived as a spy anyway, even if they're not. So that bridge has been crossed a long time ago. And to the extent that we will get our national security tools involved in this, and that's inevitable, it's going to happen. It's happening. It's going to encroach on some of the missions. So we need to be cognizant of it, figure out try to work on how we keep these things distinct where they need to be kept distinct, but be realistic that this is now part of our national security, and how do we sort of do this right. But it's not the reason to frame it this way isn't to get some Republicans on board, which it will. The reason to frame it this way, in my view, is because it just is reality, and that's where I was coming from when I started to talk about this. And a lot of my book was focused on this theme, and then how do we get the national security agencies and the spy agencies engaged in this mission in a more proper fashion, and also how do we build a national security mindset into agencies like the CDC. I mean, part of my gripe about CDC is very introspective organization, very academic in their culture. They sort of gather bespoke feeds of data, do deep analytical work, and their major communications tool is the Morbidity and Mortality Weekly Report. That's very good for doing very exquisite investigations of public health questions in sort of a peacetime setting, but we needed a wartime agency. We needed like the Joint Special Operations Command that is accustomed to getting dirty data, doing real-time analytics, and surfacing partially informed judgments, which is exactly what national security agencies do. When the CIA does an analysis, they say we assess X and we assign Y probability to that. CDC doesn't talk in that language. They say we've assessed X and we're certain. They want to be certain about questions. So you needed to change the kind of culture and mindset of the organization into more of a national security kind of posture.
So that's a really good lead into the next question, because as someone, a lot of people in this room have probably been listening to the CDC and FDA for years, like a couple of years now, talking about COVID, and like, oh, why'd they say that? That wasn't quite right. And sort of people are very critical of them for lots of reasons. But we also aren't in the CDC. We aren't in the FDA. So are there any, as someone who has worked, like who's been on that side, what are some of the misperceptions maybe that people on the outside don't understand of the way big institutions like the FDA and CDC operate that can sort of result in the communication that doesn't seem ideal, but that like sitting from the outside throwing stones if you don't know how it's being done isn't as productive as it could be? So are there any particular issues that you think we could all benefit from understanding to then think about how all of this could be done better the next time?
Yeah, I'll give a perspective of how I approach communications at FDA and then kind of lead into a discussion about CDC. My big bugaboo when I was at FDA was that we didn't communicate early enough, and we didn't communicate about things that we didn't have answers to, but to talk about what we knew, what we didn't know, and what we were doing to find the answers. Like, if we had a drug safety or a product safety issue, I thought it was very important to communicate right at the outset and say, we're investigating this. This is the little bit we know about it right now. And this is what we're doing to get answers. These are the questions we have, and this is what we're doing to get answers. And this is when we think we're going to have some answers. But people were reluctant. I mean, the FDA has changed its posture, and I think they do communicate that way. But that was a hard transition because people said, no, let's wait. We're going to have data in a week. Let's wait to say something when we have data, when we have an answer. And I thought it was very important to be sort of communicating all the way through and to frankly over communicate. You would see us put out updates on statements literally sometimes every day if there was a crisis, if there was like an outbreak of foodborne illness or during the devastation in Puerto Rico. We updated every single day, but oftentimes we would update weekly on emerging issues. And the other thing that was how I thought about this was the agency's posture traditionally, and this transition was happening before I got there, so I don't want to make it seem like I did all this, but the agency's posture traditionally was to talk to the press and then have the press communicate with the public. And I felt very strongly that communications had changed, and it's very important to talk to the press, very important to educate reporters and spend the time to do it. And I would always try to get the center directors to do long sit-down interviews with reporters to educate them on issues, to inform them about issues, and build that sort of information base and relationship long term, but also think about how we communicate directly to consumers. How do we communicate on Twitter and Facebook, and and press releases should be things that are speaking to consumers, not to reporters, because oftentimes the press releases just get put up on Facebook as articles and consumers see it. So I would, if you saw, I constantly put out statements, commissioner statements. I must have put out like 100 of them as a way to do a long format explanation. And the other challenge that we had was everything went through clearance, and it wasn't the internal clearance that was the issue, because the internal clearance was important to make sure things were factually correct. It was the political clearance, sending it to HHS, interdepartmental clearance. And that's also why I created the commissioner statements, because what I said to political leadership between us and the 110 people on this call was, I said, these are my statements. I'm a Senate confirmed FDA commissioner appointed by the president. These statements are my statements. I'm writing them. I'm putting them out. You are not going to review my statements. You're not going to, censor what I say and put it through clearance. So I used to put those out directly. I would send them to everyone as sort of an FYI. This is what I'm going to be saying in the next 30 minutes. Didn't want anyone to be surprised, but I refused to put those through clearance because I saw them as my statements. So it was a way for me to communicate directly with the public, get things out more quickly. And also Twitter was a tool for that. I used Twitter to sort of immediately inform on things. And if you looked at my Twitter account, it's been deleted. It was deleted by the person who took over after me, but the tweets are still archived there somewhere, not on Twitter. that's a whole nother story. But if you look at my Twitter account, particularly in the setting of outbreaks of foodborne illness, I would comment right away, because I thought in those were the circumstances where it was really important for the agency's voice to be in the first story. And the only way that I could get a statement out quickly was through Twitter, because otherwise it would have taken too long. So I would just confer with the experts who were working on it to make sure it was tweet something out, to make sure the agency's voice was in those first stories. This also leads into some of the challenges we had with CDC, and where I think their culture was very different. In a setting of an outbreak of foodborne illness, the first agency to take the lead is CDC. And what CDC says, let's say there's like 20 illnesses in Wichita Falls, 20 people get a terrible GI illness. CDC will go in and investigate, and they will find the source. And if they trace it back to a food source, then they will hand it to FDA, and then FDA will figure out what the food source is. And that's how the two agencies operate. CDC goes in and first investigates the cluster of illness. And then when the cluster of illness is traced back to a food source, then FDA comes in and finds the food source. That in the old days, it took a long time to find a cluster of illness and trace it back to a food source, and it took a long time to find the food source. And so that sort of sequential approach was okay. In today's world, you can find all that out up front, or a lot of it. And so the press is reporting there's a cluster of illness, and it's Jack in the Box, and here's CDC still doing the investigation. FDA can't say anything about Jack in the Box. And I'm like, we can't work this way. We have to, if we have a suspicion that it's a food source, and we have a suspicion about what the food source is, we have to find a way to be able to say that up front, because consumers can be put at risk. People need to know it's going to get reported anyway. We have to speak to it. I faced a tremendous amount of pushback on that. I started from CDC because they didn't want us going out in front of them. And it got to the point where I ended up putting out statements myself on Twitter. So I would assume the responsibility for it and the blowback. And then eventually we created this commission, this working group, to work out between the two agencies how we would do this handoff and how we would put out these statements earlier. And it amounted to FDA saying, CDC is, the statements would say something to the effect of, CDC is currently investigating a cluster of illnesses and describe it. And, FDA, at this time, FDA thinks it could be related to this. And the two agencies are still investigating to come to a conclusion. So we put out sort of a tentative statement like that, but it was a sort of illustration to me. And there were others in terms of FDA working with CDC, where the CDC was very reluctant to lean in and put out sort of a partially informed judgment or an uncertain judgment. And FDA, which I think was more consumer interfacing for the most part, I think CDC interfaces with public health agencies and providers. I think FDA is very consumer facing, felt the pressure to speak directly to consumers right up front. And this has played out also in COVID, I think.
Yeah, so that was a really fascinating to kind of hear, even within two federal agencies, how the culture is different and how that affects communication. I was asked by some reporter a year ago, because like, oh, you're a professor, what grade do you give the government for COVID communication? And I was like, which government are you talking about? Like federal government, 50 states, however many counties and cities, and none of them are saying the same thing. Or they're, the city of Austin, the state of Texas often are not saying the same thing. And so given like the reality of the way the country's governments work, how do you think we could do a better job the next time through? Or how could we improve right now so that there is a little bit more consistency, so people aren't feeling so torn in different directions by local versus state versus national government sort of communication and regulations?
Look, I think the state governments would defer to the CDC. I think in settings where you've seen the state government step in front of CDC, it's been out of frustration that the CDC isn't speaking to certain issues or isn't giving guidance that is updated enough to actually be practical. And you've seen more and more of that sort of disobedient behavior, for lack of a better word, by states and state public health agencies kind of stepping out in front of CDC because they're just kind of throwing their hands up. And I've talked to a number of governors, and I've heard the frustrations firsthand. I think this is about changing CDC's sort of approach to public health emergencies. And I think the way to do it right, so, it's an issue of resources, but it's also an issue of culture. And it's an issue of what the agency's mandate is. And, building in more self-awareness in the agency about the practical implications of what they say, and an obligation to actually, do things that could inform consumers and states and businesses, and that being part of the mission. Part of the mission is to make sure that people have something that they can tie their decisions to that's authoritative and well thought out, even if it's not perfect. But CDC, I think the culture is to get it perfect, to be really science-based, and in the setting of a crisis, that's really hard when things are moving very quickly. And I think as long as you're sort of upfront about the speculative nature of some of these things and willing to modify them as new science emerges and time goes on, it's okay, as long as people understand. And with CDC gets into trouble is they wait too long to issue things because they want to be sort of really confident, and then they leave them in place too long. So even as circumstances change, you still have the same guidance. And we see this even with like prevalence estimates and mask recommendations. So ultimately, this needs to reside with CDC. I think you need some authoritative body. I think it's about building a new sort of capacity in that organization. To me, the targeting center that is being created by Mark Lipsitch and Caitlin Rivers and Dylan George, I think what they're building there, it could be the seed of a new pandemic response sort of organization in that agency that handles these kinds of emergencies. But it's also broader than just dealing with communications in a pandemic. As I said, with like the setting issues of outbreaks of foodborne illness, with setting of flu, their communications kind of reflects the same ethos. And I think those ethos are fundamentally kind of flawed and not well thought out. And I'll give you one more example. 2018 flu season, I had just come aboard at FDA in 2017, in summer 2017, 2018. So 2017, 2018 flu season. Going into that, FDA's career staff, professional staff in the biologics center had a big concern looking at some of the early flu prevalence trends, that the vaccine wasn't covering the flu well, that there was a mismatch. And they turned out to be right. The vaccine had undergone what we call egg adaptation, and the vaccine wasn't neutralizing that prevalent strain of flu well. And it turned out to be 20%, about 25% protective against the prevalent strain of flu that season. And it turned out to be an unusually bad flu season 2018. About 80,000 people died. I crafted a public health advisory that we were going to issue that, and I was new on the job, so I was a little unsophisticated in some of these politics of interagency issues, that basically said, we are worried about the rising prevalence of flu and information on particularly bad outcomes, and we think that there may be a mismatch with the vaccine, the prevalent strain. Providers should be cautious. They should, maybe have an earlier consideration of using antivirals in the setting of high-risk patients, and just sort of a general public health advisory. I forgot the details of what it said. I put it through interdepartmental clearance, which is what you do with statements like that, and CDC blocked it and went to the secretary's office to block me from putting it out, because they said, basically in a nutshell, we talk about flu. FDA doesn't get to talk about flu. We do flu. And FDA can't say this about flu because we're not ready to make this determination. We haven't drawn this conclusion. So I took the public health advisory, I modified it as an update to the label of the flu vaccine and put it out anyway, because I said, look, you can regulate communications on flu, but I regulate the vaccine. And so we're going to put this out as an update to the labeling of the flu vaccine. So we got our statement out. CDC really didn't conclude what we had concluded in that statement. And this isn't to sort of elevate FDA, but they didn't finally draw their firm conclusion about the severity of that flu season until the summer of 2018, when they put out a MMWR saying that 80,000 people, an estimated 80,000 people had died during that flu season. And it was a particularly virulent flu season where the vaccine didn't cover the strain well. They finally did their exquisite analytical work and drew a firm conclusion. And that's not to say they didn't put out advisories along the way, they did, but it was sort of emblematic, I think, of the slowness of the agency, the careful, how careful they were and how good their scientific work was. But that doesn't work in a setting where, you need the information out so people can make better decisions about immediate risks.
Sure. Okay. Well, last question. We're starting to filter into kind of some of the questions that were submitted as people registered and the people are submitting right now in the chat. One last question too is, or another one that's popped up is, you've been a really prominent public kind of speaker about public health, going, as you said, all the way back to tweets as FDA commissioner on the last couple of years. Are there any lessons you've learned along the way? Something you learned to get better at, or a misstep that you learned to not do in the future? Like, how have you worked to get better at that over time? Are there any missteps that you learned from that you think others could maybe benefit from how you've learned to improve and do a good job at this?
Yeah, that's a really good question. I haven't reflected on that. Clearly I've had missteps. I mean, things that I've communicated poorly that were misconstrued. And, the one sort of tension I feel, and I've felt along the way, and this really isn't such a deep observation, but it's been constraining for me, is that as my audience has gotten bigger and more diverse, I found I need to be much more careful how I say things, because especially like Twitter's a nightmare, because trying to get a thought down in a short characters is really hard. But even on TV, I've had to be much more give much more thought how I say things and how I present information as my audience has gotten bigger, because everything has gotten misconstrued. And in this political environment, people are looking for reasons to misconstrue statements. And it's been really hard, particularly like on TV, because, I'll say something that is sort of thought out, I think it is, but it's long. And then there will be a tweet put out or an article with a headline that, is sort of clickbait. And I just get killed in social media for something I really didn't say. And that's been very hard. I spend much more time now. I spend much more time editing tweets before I put them out. And a lot of them I'll circulate with friends before I put them up. I never used to do that. I spend much more time prepping on Saturdays for the Sunday Face the Nation hits. I spend a good part of my Saturday prepping for that, writing out notes, thinking about what I want to say. And I never used to do that in the beginning, but I do that now. And with CNBC, I look at some of the tweets before they put them up to make sure that they're reflecting accurately what I say. That level of caution and careful attention, I did not do at the outset of this. As my audience grew, and as what I said got more people paid attention to it, which is a good thing. I mean, I'm proud of that, and I'm grateful for it. And also, as things got more politically divisive and people were looking to create wedges, I've had to be much more careful. And that's, at the end of the day, that could also be constraining. I mean, I'm sure it's been constraining. I just don't want to recognize it.
Yeah, I think a lot of people could probably agree. Twitter is a bit of a nightmare. What you were just sharing actually was one of the pre-submitted questions we got as people registering. And so the way the person asked it was, what would 2022 Scott Gottlieb tell 2019 Scott Gottlieb about the best ways to prepare for upcoming changes to American society?
Well, 2019 Scott Gottlieb didn't know that COVID was going to happen. I mean, I think 2020 Scott Gottlieb talking about what, the pandemic as it emerged. I think in retrospect, I would have been much more deliberate about talking about what we had to do in the context of what was happening at that time, because I feel like the narrative has been hijacked by critics who sort of decry certain things that we've had to do without recognizing that in that moment, it might have been the right answer, or it really might have been the only answer. Like, the example I use with people, I get attacked all the time because I supported lockdowns. You supported lockdowns. I didn't support lockdowns. I don't support lockdowns. What I supported was what we did in the spring of early summer, spring of 2020, when New York City's healthcare system had basically collapsed. We had no idea where COVID was spreading because we couldn't field a simple diagnostic tool to know where it was and where it wasn't. And it was very clear that if another city fell like New York, and this was a comment from a senior official in the White House, they said, if another city falls, we won't be able to give them the New York treatment. And what they meant by that was that they had done so much to backstop New York, and the administration did, and it was unrecognized, that if Chicago or Philadelphia or Boston became New York, they would have been overwhelmed. I mean, remember all the resources that went into New York, not just resources, but personnel from all around the country that came into New York. And New York still became a COVID-only healthcare system that needed a hospital ship and tents pitched in Central Park to even support the COVID patients. COVID patients, I'm on the board of Mount Sinai, were being discharged to hotel rooms that were turned into, makeshift step-down units. New York's healthcare system basically was breached. And if we didn't take dramatic action to slow the spread, the country would have been overwhelmed. And even in what we did, 0.3% of New Yorkers died, and only 20% had COVID in that first wave. 0.3% of the whole city's population died during that first wave. A little bit less than that, like 0.27%. So I supported what we did and the 45 days to slow the spread, but we didn't talk about those measures as something that we needed to do to deal with a catastrophic wave, and it was something that we were going to move on from. It was, and as we moved on, and we lifted those. We didn't have stay-at-home orders by this summer. As things improved, as we got better tools, as we learned how to care for patients, the mitigation that we adopted was, less intrusive. We understood that there were costs to be paid for what we were doing, big costs, economic costs, social costs, mental health costs. We didn't talk about it in that way, because I think that there was sort of this perpetual fear all along the way that if you kind of frame things that way, it's going to reduce compliance. And that, I think, was a constant communications challenge. It's another, this came up with the vaccine constantly. I started talking about the fact that we were probably going to need to develop boosters in July of 2021. I remember I think it was July 12th or 14th, because I remember it was a Friday when we put out the statement Pfizer did, and I was speaking about it. And Sunday I was on Face Nation. I got all kinds of blowback for that from people who said, if you talk about this now, you're going to discourage people from getting vaccinated. If people know that they're going to have to get a booster, they're not going to go get their first shot. They're going to lose confidence in the vaccine. And to me, that was exactly wrong. I mean, sort of hiding the ball was exactly what we shouldn't be doing. And from the standpoint of what we needed to do to prepare, we needed to undertake an outcome study. Pfizer did a 10,000 patient outcome study, randomized study looking at the efficacy of boosters. They started it that weekend. They needed to announce that. They couldn't just do it in secret. They needed to say, we think there's going to be a need for boosters. We're going to do a randomized outcome study to answer the question. You had to talk about it. And there was a lot of blowback on that. I had a pretty difficult couple of weeks for raising that issue. And frankly, in the span of 3 months, CDC went from rebuking Pfizer and others, including me, from making that statement. And it was an extraordinary rebuke. They put out a joint statement with CDC and FDA, if you remember, to basically pleading with consumers to go out and get a booster in a span of 3 months. And you can't do that. We can do that. Scientists can do that. CDC can do that. But the average consumer, if they hear messages that are that divergent over such a short period of time, they get confused, they lose interest. So we needed to be, I think, all the way through sort of more deliberate, more honest, and speak more about why we were doing, when we were doing it, what we might need to do in a way that took some risk that if you said lockdowns are temporary, people might not stay in their homes. If you say you might need boosters, some people might not go out and get their first vaccine. But if you do it right, if you communicate right, I think that the risks to these kinds of things are, and sort of reducing incentives to comply is much less than the risk that you confidence over the long run. And I think we lost confidence over the long run.
Oh man, there's a lot of follow-up questions that I want to ask and line up with things that we're getting through kind of the chat. And well, maybe this is something that, because you've talked about, like, you were attacked for supporting lockdowns, and it's, we can all see, Dr. Fauci who I assume, you've worked with and spoken with, and I know he's become someone who has also been kind of attacked for political reasons too. So I don't know if you're willing to share, like, the way you kind of talk through that, work through that, advice you give each other on how to keep trying to do the thing that you clearly think is important while you're being attacked for these different things that you're saying for public health and scientific reasons.
So I lost you. My communications got a little shaky there. I apologize.
Oh, no, sure. No.
So I got the part where you said about being attacked, but I don't think I got the question.
Yeah, no, it's okay. I thought maybe you were just like really intent listening to that question. I was like, nope, I think you froze. you've spoken about being attacked. We can certainly see Dr. Fauci and others who I'm sure you've worked with, I'm sure you've communicated with for like work reasons. But I don't know if you are willing to share or have kind of the behind the scenes, like how do you work through that? How do you give each other advice or support each other to keep doing the work and leadership that you clearly think is important because you keep doing, but withstanding some of those challenges and attacks?
Yeah, look, Tony's a good person, and I think that the circumstance he's in and the way he's been attacked and objectified is extraordinary. I mean, there's nothing I can say that I think even approximates the situation he's in. And I think the situation that he finds himself in, look, it's a reflection of our times. It's a reflection of the very difficult moment that we find ourselves in with COVID and the huge human costs on every side of this equation. But I also think it's a reflection of the role he had to play in terms of being a voice for things, for policies that were going to be unpopular. And whether the policies were right or wrong, they were the policies. They're what the administration decided to do, including the Trump administration. I mean, President Trump supported the 45 days to slow the spread. So people who attack me for lockdowns, that was the White House that did that. I supported the policy. But Tony really became the face of the policy. Someone had to play that role who could communicate well and had credibility, and that fell to Dr. Fauci. And so he's become, I think, associated with things that now, in some circumstances, and many actually, are deeply unpopular. And I think he was just fulfilling sort of his public health obligation to the country. So I don't know what I could say that would be how I reflect on this and advice I would give other officials, other than, when you get into these jobs, and look, I was on the receiving end of a lot of difficult criticism, threats that at times felt dangerous, nothing like what Dr. Fauci's facing, but to me felt dangerous at the time. The things that we were pursuing, the stuff we were doing on vaping, the stuff we did on Kratom, believe it or not, became a real lightning rod for me and opened up a lot of sort of dangerous language that was directed at the agency and at me in particular. I think that I think Tony's done this. You got to do what you think is right and be undeterred by it, because if you take these jobs where you feel like, where you have a public health mission and you feel what you're doing is right in terms of discharging that mission, and you feel like you're doing it in an improper way, and I'm sure Tony has confidence that he acted in the right way at every step here, or most steps. I mean, I'm sure he's reflective too and feels that he's probably done some things, he could do some things better. But setting that aside, you got to just kind of work through it and not allow it to deter you. Because if you change the policy, because you're personally threatened in these jobs, then you're going to be not fulfilling your obligation. And so, that's the downside of stepping out into these public roles in an environment that we're in today, where there's a lot of vitriol. And I'll just sort of reflect on Twitter, because we started there. This is my gripe against social media, because I think social media has been a tremendous tool in terms of facilitating information and exchange of ideas. It was very valuable to me when I was at FDA in terms of like looking at comments and getting real-time feedback on what we were doing. I would look at it when I was giving remarks to see what people were saying about what I was saying, and it helped me adjust my message, and I learned a lot on it. Not just in terms of the information exchange and reading from reporters and stuff, but seeing what people said about what we were doing. But part of it also, I think, the downside is that it sort of reinforces the anger and the hatred, because people sort of compete sometimes on Twitter to put out the most caustic messages, and I think that it normalizes the behavior to some extent. It normalizes the dialogue in a way that was harder when you actually had to kind of talk to your friends, or go to the local soccer game and on the sideline say, hey, what do you think of this? You suddenly said, maybe I shouldn't be saying that. There was like some social pressure to moderate your behavior. But on Twitter, there is no social pressure to moderate your behavior. The social pressure is to say even more extreme things, because that's how you break through. So I think in that regard, it's kind of normalized some of the anger.
So it's interesting here you kind of talk about paying attention to Twitter as like a way of sort of starting to listen or hear back. Twitter is certainly not the real world, thankfully, but a lot of almost everything you hear about health comm during COVID-19 is like, what is the CDC saying? What is the FDA saying? And we forget that everyone needs to listen to. Our country is a big, diverse place. Do you think federal agencies, governments, the people working in public health have good systems for actually listening to the public and all the different audiences they're trying to serve? Or is that a gap that we could improve on for the next time as part of building that trust and like they're actually listening as opposed to just trying to say things better?
Yeah, I don't think that we have good mechanisms for gathering feedback. And I think it's very much dependent upon the people in these roles. And the more that you get sort of put upon, and I saw this when I was at FDA, the more that you're sort of criticized and you kind of pull back. And that's the most dangerous thing, when you kind of push back from the table and you stop listening. Because the dialogue is so difficult to look at. And, I find myself in that circumstance a little bit. I don't like reading the comments anymore. I don't like reading the mentions anymore. Oftentimes I just look at the verified comments, which is terrible, right? Because then I'm just looking at people with blue check marks who are commenting on my stuff and not reading through. I still do it. I still go through the mentions, especially after I'll do TV or something, and I'll look at how people reacted to it, so I can kind of course correct my message if I have to on Twitter. But it's hard. It's hard to look at that because it's pretty vicious sometimes. And so I know when I was in the job, it was hard too. Now, when I was in the job, the kind of stuff that I see now was less frequent. Now it's been the norm. I think partly because so much is at stake, partly because it's such a bigger issue. But even though it wasn't the norm, when you were seeing that kind of vitriol when I was in the job, it was hard to go through it. But I did.
It hurts as we're still working through COVID-19 to think about kind of the future threats. But you've had a lot of different sort of angles in and probably thinking about this. What are your thoughts on how to sort of work against vaccine hesitancy, which sure seems like it's been a bigger deal now and might kind of spread back to other vaccines that were more well accepted? What are thoughts on kind of how we can do a better job sort of addressing vaccine hesitancy? Because it's going to become kind of an increasing challenge, I'm sure.
Yeah, well, look, first of all, I don't think that the vaccine hesitancy that is sort of political in origin is as widespread as we think. It's a vocal group of TV commentators and people who, sort of buy into a particular point, but it's small. 87% of adults over the age of 18 have gotten at least one dose of vaccine. Vaccination rates among children are far lower than what we thought they would be, and far lower than I think where they should be. But I think that and there was more hesitancy with parents vaccinating the kids, but I think that that's kind of always been there. Parents are always hesitant and reluctant to subject the children to medical treatments, medical procedures, and I think that kind of reflects usual norms, and that will slowly evolve as people get more confidence around what are arguably still new vaccines, even though they've been put in billions of people. Honestly, the way I would address this is to push back from the table a little bit and stop trying to talk about attacking the misinformation, and stop with the mandates and push back a little bit. Recognize we've had a tremendous public health achievement. I mean, this administration deserves tremendous credit for being able to roll out a vaccine as effectively as it did. I never thought this many Americans would ever get vaccinated, just because it's so hard to get a lot of Americans to do anything. I mean, we're a big, diverse country, and just try to get good information to the marketplace and not make people who have reluctance feel like this is something that's being compelled. And we now, frankly, have the luxury to do that. Prevalence is declining. Hopefully, things will be quiescent this spring and summer. We may need to get boosters in the fall, but over the summer, I encourage people and not have this be such a top-down, politically divisive debate for the small percentage of people who are still who are still kind of vaccine holdouts. And the last thing I'll say is when you look at the surveys and you look at people who are unvaccinated, the biggest reason people remain unvaccinated, setting aside still access issues, because there are still access issues, although I think the administration has done a very good job trying to reach hard to serve communities, but setting that group aside is fear of needles. So it is not political. And, I think the government's trying to compel me to do this and I'm going to resist. I don't like needles. That is still the number one reason why people choose to get a vaccine. The surveys that I've looked at, and I've seen pretty good consumer data.
We have a colleague who studies visual communication and health, and she's very frustrated every time a news article about vaccines is like a picture of a crying little kid getting a shot. It's like, stop showing that to people, because that is such a big reason some people don't get vaccinated or don't want their kids vaccinated. We're getting close to the end here on time. But one other follow-up question we got from the audience was really early on. You were making the point that to use sort of public health sort of infrastructure in the field is a little left of center, as you would see it. And so what would it look like if it was more moderate, or was kind of sitting right at the center? How do we move towards public health being less politicized in general?
I don't know. That's a hard question, and I'm not sure I have the answers, but I think that it's not moving in the right direction. I think that there are doing public health right requires you to have really honest conversations about really difficult issues that are very politically sensitive. And the environment we're in, where if you sort of, and part of it's how we communicate. I mean, we're communicating on imperfect mediums that can be easily misconstrued. So we're communicating in a bad way that doesn't lead itself to sort of thoughtful, reflective commentary that captures the essence of an issue. So that's a problem. And then everything you say gets extracted into a soundbite and turned into clickbait. So that's a problem. And then we have to do this right. We have to communicate about very difficult, sensitive issues that we're in like a cancel culture where if you say the wrong thing about the wrong issue, you get attacked. And that was how I felt talking about CDC's inability to surface information about the COVID epidemic early on, and misinforming the Trump administration, where I was attacked for creating an apology for the Trump administration, which was not what I was trying to do. I was trying to make the point that the Trump administration had bad information on which to make decisions, because the agency that was charged with doing it was doing an inadequate job, which the Biden administration soon learned was in fact the case. And that's not even, I don't even consider that a delicate issue to talk about. I think that there's far more delicate issues that we need to have open, honest discussions around that are hard to have. And to the extent that they're hard to have, and to the extent that conservatives feel somewhat constrained, and I think that that's true, and I'm not trying to be whiny, I'm just saying I think that that is true. I feel it. I don't think we're having as robust of a debate as we ought to be having to get at good consensus-driven solutions to really hard issues.
Well, we'll finish with a really uplifting, optimistic question from the audience too, to kind of close out. So the question here is, what's your number one hope for the future direction of public health in the US?
Look, my hope is that what we've gone through demonstrates the importance of having strong public health institutions, properly resourcing them, the importance of public health officials in a setting of a crisis, and kind of elevates the field. My worry is that there has been skepticism built of public health officials, that it is broader than just a right-left debate. And I think people in public health community too often dismiss it as just a right-left debate and think that this is just Fox News beating upon the public health establishment. I think it's much broader now. I think that there is a broader section of the population that feels like the information wasn't good, that the advice wasn't good, that public health institutions didn't do an adequate job, and the willingness to elevate the field and resource it and build out stronger institutions is not there. The consensus that we need is not there. And that when we look to Congress to legislate on this, we're going to find it's not just Republicans voting against these measures. It's going to be broader. That's my fear. I think that if we're kind of eyes wide open about this, we can tackle it. And part of it's going to, I think, doing kind of a post-mortem and reflecting on, and being kind of candid about where the decisions were. Some of the policy steps were wrong in retrospect, but they were right. That doesn't mean they weren't right in the moment. But we need to acknowledge that, and then we need to talk about that what was right in that moment wasn't right 2 months later, but we ended up leaving it in place for 2 months, and that was wrong. That was the mistake. The mistake wasn't doing it. The mistake was not lifting it when the situation improved and taking some risk, because it was always going to be some risk. I'll just pause here. You're seeing with the masks now. Is it too early to lift mask mandates in schools? You are clearly going to potentiate some spread by lifting the mask mandates in schools. The masks, no matter what we say about their utility, they're providing some measure of risk reduction. And when you take them off, there's going to be more risk. But relative to where we are in terms of prevalence declining, with a less virulent strain, with so much of the population with immunity, with the accumulated costs of the masks, because they are disruptive to a school day, we ought to be leaning forward. And the problem is we have a very hard time, as I think, I'm sorry, I'm rambling, lifting things. And I kind of think we need to have that conversation now and reflect back. And that will be a way, I think that's the way to re-earn some trust and credibility.
That's a great way to wrap up. Well, Doctor, we just want to say thank you so much. This is, this conversation, this event is always a really excellent chance to hear from someone we wouldn't otherwise get to hear from. And so I know I thought this was I learned a lot today. I have a feeling a lot of people in the audience learned a lot today. And just really want to say thank you again for giving our 2022 McGovern Lecture in Health column. This was a real treat and very much appreciate the opportunity to have spoken with you today. This is great.
Thanks for having me. Really appreciate it.
All right. Thank you all for being here today.